right. Welcome back, everyone, to our third advocacy meeting. Today, we're going to be going over a really cool topic, and I hope you guys enjoy it. I don't have any slides to present today because I don't have any announcements really to make, except for that we are working on a toiletry drive that we're going to be hosting through Eventbrite. So be on the lookout for that if you want to contribute to local service. Apart from that, I'm going to let Ruhi take over for now, and she's going to present on her topic today.
Hi everyone. So this week's advocacy topic is global healthcare systems. So I'll just get started and share my screen 1 sec. Can you see my screen?
Or no, you have to wait. No, the other one.
I got it. Right. Can you guys see the presentation?
Yep.
Cool. Awesome. Okay, so so this week's topic is global healthcare systems. We'll also talk a little bit about nutrition, and I'll just get started.
Hi guys, I'll be talking about Japan. So Japan has the longest life expectancy on Earth and spends half as much on healthcare as the United States. And this is largely in part to their universal healthcare system where all the citizens are covered. So Japan has very low cost. And this is largely in part due to the fact that the Japanese healthcare ministry tightly controls the price of healthcare. So this means that insurance companies are not the ones setting the rates for treatment, and they can't deny claims. This also means that every 2 years, the healthcare industry and the health ministry negotiate a fixed price for every treatment and medication. Unfortunately, the downside of this is that Japanese doctors make less, and that the current system will not be sustainable in the close future because payment for healthcare takes up 35% of the total national budget. And also because Japanese has the highest proportion of older adults in the world.
So for China, they have private and public options for healthcare, and citizens who are employed who live in cities are required to enroll in the employment-based program, and that's kind of private insurance. And for low-income citizens or people who are unemployed, they have a rural plan, so they can kind of choose what they want to have provided to them. And the National Health Commission is the main agency for Chinese healthcare. And toward the right, you can kind of see a picture of the issues with the Chinese healthcare system, but it's pretty good because it's public. And they have a lot of the citizens who live in rural areas can't really have access to good healthcare because a lot of the rural doctors aren't as well educated or paid as well or have as much resources, so they can't provide the same level of care as they can for people who live in the cities, which are way more expensive.
Hi, these are Githica's slides, but she couldn't make it, so I'll be presenting them. So most European countries have a form of universal healthcare that's funded by taxpayers, and France prioritizes equal access to everyone, and because of this, almost everyone is guaranteed statutory health insurance, and those that can't afford the supplements can get them, and it's a similar system to Medicare and Medicaid, but those from low income brackets have these options. Germany has privatized but regulated healthcare options, and this means it also has the most diverse options. Low income healthcare is required, but people have the option to buy private healthcare. Most people do choose to stay on the public one though. And the Netherlands and Switzerland have systems similar to the Affordable Care Act in America, and citizens are required to have healthcare, but it's not provided by the government, and out-of-pocket expenses are substantially less than they are for American citizens. I'm going to talk about Brazil for South America, and public healthcare is provided to all Brazilian permanent residents and foreigners, basically anyone who's legally in Brazilian territory, and this is through the unified health system. A card is required to access any healthcare system like hospitals or doctors, And around 70% of Brazil's population uses this system, which is actually a huge increase from like just like the 1980s when healthcare wasn't seen as a basic right by the government. Um, However, like even though the system has improved a lot, it still suffers from a lot of socioeconomic disparities. So more rural regions and more rural, lower income regions don't get the same resources, even though it is public health care. One of the big focuses of this system is primary health care through the Family Health Program. And this was implemented in 1994 with a huge focus on making sure families and communities get access to doctors. And there are, like I said, major improvements, but a lot of issues are still remaining, especially challenges from like infectious diseases that's typical of like developing countries, but also like diseases such as cancer that are more associated with developed countries.
So now I'll talk a bit about the US, and just heads up, I'll just talk about how the system kind of works, and then I'll hand over to Julie, who will talk about the Affordable Care Act, and then I'll come back to talk about the economic side of United States healthcare. So just for like a brief overview of how the United States healthcare system works is that 2/3 of the population, or sorry, not 2/3, but like a good amount of the population's on private health insurance, usually through employers. So about, I think it was like 150 million people have insurance through their employers. And through that, so there are like three parts of like the insurance structure. So there's a deductible, which is how much you have to like pay the insurance company before you get any coverage at all. Then there's a premium, which is the amount that you pay every year for health insurance. And you have that amount, like you have that payment whether or not you use the insurance. And your premiums can go up or down depending on how high risk you are and how much the insurance company anticipates that they will be like paying for your healthcare. And the third part is the copay. So that's how much you pay out of your own pocket after health insurance at like any doctor's appointment, or like, you know, if you have to go to the hospital for something, there's going to be like an out-of-pocket expense as well. So usually the United States healthcare system is described as being very expensive, largely because of private health insurance. So premiums can be like extremely high, and people who don't have employer-based healthcare have to pay like very high amounts in order to be covered, or have to pay ridiculous amounts for drugs or for medical care. And a lot of the expenditure from health insurance goes towards service costs. So it goes towards like the cost is like the doctor's salary and how much doctors like get paid, which is a big reason like doctors do get paid a lot, because that's like where a lot of the cost of healthcare goes. And then just a bit about like the structure of healthcare itself. So within an insurance package, there's a list of doctors that they cover. So usually you have a primary care physician, which is like this guy, and then they refer you to different specialties as needed. And that's kind of how the United States works in terms of healthcare. And then about a third of the population is covered by public healthcare, which Julie will talk about now.
Okay, so the ACA, or the Affordable Care Act, also known as Obamacare. So this is, you probably heard a lot about this in the news. This was implemented in 2010 and is still like used. It's still used now, but it's, you know, under. I mean, it's being re-examined by Trump. So some of the pros of the Affordable Care Act is that it was initially there to, it actually helped competition. What I think, which was a misconception, that it was, you know, people who, you know, were Medicare for all didn't think that it would promote competition, that everyone would want to be on, you know, public health care. But because it was supposed to be so good, you know, private insurance had to compete. So a lot of private insurances actually like joined up with the Affordable Care Act to make some of their services more affordable. So Another pro is Medicare. So Medicare was expanded under the Affordable Care Act and covered, so it's for people ages 55 and older, I believe. And you know, most of their care is like covered by Medicare. You have to have a secondary insurance, and usually like with the secondary, you can get, you know, up to a certain point, most of, you know, your doctor's visits, like physical therapy, occupational therapy, like completely covered. Medicaid, sorry. No, I didn't mean to. Medicaid. So Medicaid is for people who basically make under the poverty line. So it was good because it, you know, it increased over 12 million people who were previously uninsured were able to be insured with Medicaid. I'll get to the cons of Medicaid later. So if you have pre-existing conditions, with the Affordable Care Act made it illegal to discriminate. If, let's just say, you have diabetes or you had cancer, insurances can't like refuse to cover you. And then also, if you're you can be covered on your parents' insurance until age 26, which is great because if you're a college student or you're in grad school and you're not really working a full-time job, you can just use your parents' insurance. And they also made it really easy to navigate and understand on the website. If it's like healthcare.gov, if you go there, they make it really easy to find which insurance is going to be right for you depending on what state you're in and how many people are in your family. And then also, you know, I remember going to, you know, the doctor before, you know, like in 2009 or before that, and my mom had to read all these, you know, forms and paperwork before I got treated. But now it's summarized, so it's, you know, in lay terms, so it's easier to read and understand. And also, a lot of stuff got covered, like birth control, flu shots, annual visits got covered by the Affordable Care Act. Okay, so cons. So arguably, or pretty objectively, our care is not enough for what we spend. So like, I forget who was saying it, but Japan spends, you know, half of what we do, and they're on their healthcare, and they get, you know, probably better care than we do, or just as good care. It's really expensive. I think Rui said this, it's 17% of our, what? Oh, you didn't say it. Okay, sorry. So we spend 17% of our the federal taxes on healthcare, which is a lot. So Medicaid, the issue with Medicaid is that it's good if, you know, you make below the poverty line, but let's just say that, you know, you get a great job and, you know, you're making more than, you know, you start making more money and go into that middle income tax bracket, then you don't qualify for Medicaid anymore and you get kicked off, and then now you have to pay for your own insurance. And if you have Medicaid, services are generally free. You have low premiums. You don't have to pay like it's, you know, it's basically no cost healthcare. The quality of care is not as good because also health, like hospitals and doctors who treat Medicaid patients don't get reimbursed the full amount. Same with Medicare. So a lot of doctors, you know, to make the money that they feel that they're worth, don't want to take, you know, public insurance, which sucks. So their care is not good. They have to remain in the tax, in the below the poverty line, which is such an issue. So pretty much the goal of Medicaid is to keep the poor poor. That is, if you take political science, class 141, Professor Piston explains it like really well. So also private insurance, they started pulling out of the Affordable Care Act and teaming up with them because it's not sustainable, which is another point. Like they weren't getting enough money. It made, premiums too low, and they didn't feel like they were, making enough money off of this. And then also people who already had private health insurance by their jobs weren't making, like, it didn't really change anything for them. So it really only, like, the only people this really helped were people who, are under 26 years old, people who have pre-existing conditions, and then the 12 million people who, which is also like 4% of our population, get insured. And so that's a very little amount compared to the rest of America. Yeah, there were just some graphs about it, but it's fine.
Okay. So now to talk a bit about like the economic side of it. So this is a graph of healthcare expenditure as a percentage of GDP from like 1960 to like about the present. So as you can see, like our healthcare spending in the United States has been increasing ever since like the 1960s, and now it's like up to 17% of GDP, sorry, as Julie was saying. But even though like we have this like massive expenditure, which is like almost a fifth of like the government budget, only 34% of people are actually covered by public health care, which is much lower than a lot of the other developed countries in the world, even though we're spending more than all of them. So a big reason for that is what I said before, was that a lot of healthcare expenditure goes towards like service taxes or like service costs. So for example, in hospitals, they can pretty much set the price for what they're doing at whatever they want to set the price at. For example, if they want to charge you for like a plastic cup, they can charge you as much as they want. So because of that, hospital visits can get to be extremely expensive. And same with like taking an ambulance, like, like we've all heard about that, where because hospitals can like have the ability to set the price at whatever they want to, they typically do that and just make their visits extremely expensive. Another thing is that doctors are very highly paid in this country, which is, like why we have to spend so much on healthcare. And then the third reason is that like drug prices are really high, because just like hospitals, pharmaceutical companies can basically set their price at like whatever they want, because people will pay for their drugs no matter what. So because of this combination of like high drug prices, high service prices, and basically an unregulated market in terms of healthcare expenditure has continued to be really high in the United States, and our public healthcare system really isn't worth it right now, because it's almost a fifth of our expenditure but only covers a third of our population. So yes, that's kind of the economic side of it. And to go on to migrant and refugee health, I'll pass it to Vi.
Hi, it's actually V, but all good. So I'm going to talk about the healthcare resources for refugee and migrant populations. As you can see here in the diagram, nearly 80 million people are forcibly displaced worldwide at the end of 2019, which accounts for 1% of the world's population. So even though that the refugees and migrants have the right to health, they often lack access to health services and financial protection. So therefore, there are a lot of organizations around the world that help reduce this kind of accessibility. We can see like United Nations Refugee Agency, or Doctors Without Borders, and the Red Cross. In general, they provide medical and mental health care to refugee and migrants population, especially in many South European countries like Greece, Hungary, Serbia, where a large amount of the large number of population are refugees. I want to emphasize the important part here that they provide mental health care to these populations, since a lot of people who come from developing countries don't really acknowledge mental health, and thus they don't really care about their mental health. So it's really nice of them to provide this kind of service. They also like provide hygiene items and conduct search and rescue missions along the route between North Africa and Italy. It's really helpful for this kind of populations. You can move to the next slide. And in the US, we have a lot of healthcare resources for the immigrant populations, such as the Affordable Care Act that Ruhi just talked about. I should say that most of them are like free, but as an immigrant, you have to reside in the US for at least 5 years in order to be considered to get Medicaid or Medicare. There's a stigma that the immigrant populations don't really like contribute to the healthcare industry, but it's actually wrong because they contribute more to Medicare than they receive, and about 60% of undocumented immigrants use healthcare as compared to 80% of US natives. So in general, that they contribute more than they receive healthcare. And another part of healthcare resources is they can use interpretation in hospitals, in person, via phone or remote video app. Most of them are like state funded, but some are like 50% state funded. So some of the in some areas you cannot really get interpreters, which is a language barrier for many people that's from immigrant populations. And the third part is telehealth, which is really useful, especially during COVID-19. But some will face the limited access to technological devices, which prevent them from getting healthcare.
Okay, so these are Yashasvi's slides, but she couldn't make it today, so I'll present them for her. So she was talking a bit about nutrition in migrant populations. So the first thing is that there's a goal called the Millennium Development Goal, which aims to reduce malnutrition across the world. And it's basically like an initiative which works with, I guess, impoverished populations to improve nutrition. The other thing is that in migrant populations, the migration can affect nutrition in like different ways. For example, it can alter the amount of like which nutrients that you're getting based on where you're migrating from, where you're migrating to, and that different places have different diets. So like for migrant populations, their diet changes drastically as they migrate. So the nutrition that they get also changes. For example, in Europe, a lot of immigrants come from low-income countries. So diseases such as obesity and other nutrition-related diseases are prevalent among mostly immigrant groups, for example, South Asians. In addition, migration also impacts the people who aren't exactly migrating but are related to the migrants. For example, when a person migrates, the people in their house have more resources to contribute to their nutrition and less mouths to feed, as Yashasvi said. However, there's also a great negative effect on the family of a migrant because of less labor within the household, so less income by generation. And as a result of less income, there's also a decrease in like the nutritional value of food or like the availability of food. Yes. So I think also malnutrition in children is a huge issue when it comes to migration, as well as how well families are able to survive afterwards. Sorry about that. Okay, that's all we have, but thank you guys for listening, and I'll open up for discussion now. So just like as a discussion question, like one thing I noticed is that the United States does spend a lot more on health insurance, but doesn't really get as much out of it as other countries do. So maybe we can talk a bit about like ways to improve that and like what we can change as a country.
I think as it was mentioned in the presentation, a lot of the money that is actually going into the healthcare system ends up in physicians' pockets. And although it's nice to have people who work hard to make a lot of money be paid back into that system, I think most of it should be going towards the patients and into research and development, as well as ways to improve like hospital care in general.
Thank you, Joey. Yeah, I know like a lot of us are probably like pre-med, so you know, for us like listening to this is kind of scary that like, yeah, it is.
I was gonna say, like, I think doctors, you know, want to get paid so much because they, you know, had to pay their way through medical school, and that's like so much, you know, money and so much time that, you know, like, and studying, you know, that it's like they want to make back, you know, also like pay your student debt and all this. So I feel like if what like NYU did, and I think some other schools did, make it, you know, free, then, you know, like doctors wouldn't want to be, or maybe it would be okay to pay doctors a little less to, you know, save our healthcare system.
Yeah, I was actually talking to like my roommate about that earlier, how I think like subsidizing medical school could really help like with the, I don't know, with like the costs and like how much is going to physicians from like the cost of medicine in the US. I feel like medical insurance is like a huge big black box for me, so I don't understand it at all. But yeah, so I don't have that many like useful comments.
Yes.
But I do agree with you.
Yeah. I was shadowing a doctor over the summer. Sorry, Zach.
Oh no, I was just gonna say, like, I think not a lot of people realize is that because how like ingrained, I guess, insurance kind of is into like the medical like sphere that we have now. Like, there's almost no place for a patient if you don't have like insurance. Like, if you go to the hospital, you're screwed, and you're gonna be on payment plans for years and years to come. But what that pretty much becomes is like, it's okay, you know, for a hospital to charge $50 for a single Tylenol because the insurance company will pay it. Like, it's not like, while yes, like doctors do get paid a lot, like for the services that they provide in a lot of cases, I'm not gonna say they're completely like fairly compensated, but with the amount of like, for example, my cousin is turning, I think 35 this year, and he's been in medical school and 2 fellowships and residency and just finishing up now when he's 35, which is kind of crazy to like think about, because I'm 21, and that would be 14 more years of schooling before like I actually like make any sort of money. Because I actually was surprised, in residency you work approximately like 80 hours a week nearly, and you get paid usually less than $60,000 a year, which is like, it's not sustainable for a lot of people, obviously, and only if that's why I think it's much more than just getting into med school. That's not like obviously the end all of, you know, making a lot of money. You still have a lot of like years and years and years of hard work to even get to the point where you can potentially make money. And then even after that, it's like you still have to find a job somewhere that would even pay it. But I think like the problem isn't like how much doctors are individually paid, but more like how ingrained insurance is, and then that results in them being able to charge pretty much whatever the hell they want. Yeah.
Yeah, Zach, I agree with you. Like what I was saying was like this doctor I shouted like over the summer was telling me about how like I live in New Jersey, so she was saying like a lot of the hospitals in New Jersey have become like so corporate to the point where like they're literally charging like whatever they want, and they're like cutting deals with insurance companies, which make it more expensive for a patient to get like care from a private practice and from the hospital. So they're like in a lot of ways doing is like pushing patients towards hospitals where they can then charge like whatever they want. And it'll be like for like dumb things. Like I was watching a video yesterday, and it was like you can charge money for like cotton swabs if you want, or like plastic cups, or like band-aids, or any of that. And it's like a lot of it is inflated, I think, like within the system itself, not necessarily the doctors. And the other thing is like doctors also get paid a lot because they have to pay a lot in malpractice insurance, which is like a huge percentage of their income. So that's like also a like big hidden cost. And then yeah. But I think Julie is right in like medical school. Like it's really it's like BU medical school, like the tuition 70,000, like which is ridiculous. So I think lowering the cost of medical school will go a long way in helping to fix like the healthcare system economically.
Yeah, I just think the problems like with regards to price are just so ingrained at like every single level. For say like an MRI machine costs like a few $1,000,000, yes, but it's like then like hospitals will like happily charge you, $20,000 for a single MRI and not really care because they have to make their money back, yes, over time, but like when they're seeing so many people each day and doing all that, they make a lot of money.
Yeah, well, hospitals are, and like all, I think most, healthcare facilities are for profit. So yeah, like my mom, so she's a physical therapist and I worked at her clinic. So I learned a lot, too much, arguably, about insurance and how messed up it all is. But one of the really interesting things is how like the quality of care just like is shit because like, or at least at her old clinic, because like they would double book people. So in 1 hour where you should really be seeing like, like 1 or 2 patients, you're seeing 3. So imagine going for PT, you're paying this like $80 deductible, or, your insurance isn't going to cover it, so you're paying like $120 out of your own pocket for each visit to be seen at the same time as like 2 other people. Like that sucks. Or to be like, and then you're passed off to an aide, like that sucks. So it's like, and when you go to the emergency room, like it takes like an hour for you to get seen by a nurse to do your intake. And like it's like we're paying so much in like insurance dues and co-pays and whatever for like really bad care. So it's just like, it's so frustrating. Like, why?
No, I just looked it up because I haven't heard that before, but 62% of hospitals in the US are nonprofit, 20% are government-owned hospitals, and then only 13% are for-profit hospitals.
Okay, so I lied. Sorry.
No, but just like, I think a great example of this is, so my dad is an OBGYN, and he had a patient come in. It was pretty much like an emergency situation. The lady was bleeding really badly, and he had to put this device in. I'm not too well versed in everything, I'm not gonna lie. But the device itself costs him, I think, $1,600. That's how much he has to pay to even have one in his office for whatever reason. And he always keeps a few there just because he has to for situations. But so if a patient on, say, a normal insurance comes in and needs to get this done, the insurance will end up paying approximately $3,000. That includes like the office visit, the actual device cost, and the actual procedure itself, which takes a few hours. So in retrospect, it's not much. Like what, $1,400 sounds like a lot for an afternoon and stuff, there's a lot of like additional costs and everything that makes it not as much. But for example, if the patient was on Medicaid, right, Medicaid would pay overall $1,200. That's how much my dad would get, which doesn't even, for example, cover the cost of the device. So he's literally losing money, you know, on seeing someone and taking care of them. First of all, my dad would never turn anyone away. He would never, he doesn't really care as much about like, say like, hey, I'm going to make this much money about it. His goal is to obviously help people, but it puts doctors in a really bad situation when the government's like, we'll give you this. It actually, like, we know you're pretty much losing money on it. And the whole, it's just flawed from every level, I'd say.
Yeah. No, like my mom, the clinic I was talking about, they didn't even take Medicaid. They only took Medicare. So if you have Medicaid and you want to get physical therapy, I'm from Connecticut. So if you want, if you have Medicaid, you want to be seen by a physical therapist, you have to go you have to go to the outpatient PT clinic by that's part of the local hospital.
Yeah.
Which is also shittier care because they see so many people. So it's if you're that, I think I said this in the presentation. So if you have Medicaid, you're getting a lesser quality of care. And so and then you don't get, and even with Medicare and Medicaid, they don't reimburse the doctors to the full amount. So it's a lose-lose situation.
Yeah, I'm trying to pull this up if I can. I'll let you guys know. But so freshman year, I did a project in my, it was some engineering coding class where we pretty much took probably 200,000 data points regarding how much was paid for a procedure. And you could pretty much put in the state where you are, what procedure, and it showed you the highest price that Medicare paid and the lowest price. And the disparities are very surprising. I guess I'm going to try and find it. It's somewhere on my computer. I don't know. Okay, you guys can talk about other stuff while I'll try to find it.
I think on the point of Zach's point being that it's flawed in every system, I feel that a big part of it stems from the production and the distribution of medical equipment in the first place. There are a lot of companies that will sell, masks, especially right now, and it's such a high premium because they find an opportunity to make profit off of it, and they're no longer in it to, better society or to give it to people who need it, but they're in it now for making money and making it out of an opportunity. And going back to his topic about MRIs, although it does take a lot to make it, it does not constitute the multi-million-dollar cost of the machine.
No, I think you're absolutely right. And even in other countries, medicine and medical equipment just doesn't cost as much. It's mainly in the United States that this is, it's kind of like a bubble. It's kind of like a pharmaceutical bubble and like a biotech bubble as well, where it's these prices just are not justified at all. So I think we're all just kind of screwed.
I'm just going to share my screen. I think you guys still hear me?
Yep, you're good.
Okay, so say Massachusetts. This is what we made. So say Massachusetts, and let's see, you have a intracranial hemorrhage. All right, so you press search. Does it even work? I don't even
It says
remember.
on the top, it's looking for the average price of the procedure in the state. So that's what this does.
Yeah. Okay, the graph isn't loading for some reason. I'm not surprised. But as you can see, so for the same procedure at Winchester Hospital, Medicare paid $10,000. Well, here at BMC, oh, funny, they paid $24,000. So there's a massive disparity in the same things being done. So let's see, heart failure. I want this histogram to work. I don't think it will. Okay, it's not, but like the same thing, like BMC #1 at over double the price of this other hospital. And it's throughout the entire system where like anything you look, there's just gonna be like massive disparities. BMC is pretty expensive, goddamn.
Another like big reason for like that disparity, I actually saw like this too, was also the price of healthcare real estate, where like it's much more expensive like in like a major city than in more suburban or like rural areas. And then also because they're probably paying their doctors a bit higher as well. To be like at BMC, it is one of like the best hospitals in the country. So that's probably like another reason like for like the disparity.
Yeah.
But still
There's
kind
tons
of
of reasons as to why, yeah.
Yeah, and another reason that I think is because most of the patients that go to BMC receive Medicaid. So that's why the cost of them is like much higher, because eventually the government will pay for it anyway. So they will make the price of treatment more expensive.
No, it's only for Medicaid. The only data that was available publicly was for Medicaid patients. So all the information it has is solely Medicaid patients. Yeah.
So that's just like the price of like the procedures at the hospital.
Yeah, so like per billing code, like say like everything is broken down in insurance by a billing code. It's all like a set of like 8 numbers or whatever it is, and that defines pretty much every single procedure that can be done in anywhere. So like the same price, like the same procedure at one place and how much it costs at a different place. Pretty much. Yeah. Like while it's probably like obviously different care versus like Winchester Hospital and BMC, like technically for like the billing aspect of it, they are billing the same exact procedure.
Yeah. Another reason is like they're like they know that people are gonna pay for it, like if you don't have another choice, and like people like will pay for it. So I think that's why it's also very expensive. Yeah. If no one has anything else, then that's all we have.
Thank you, Ruhi.
Yeah, no problem.
Good job to everyone who presented today.
Yeah, good job, everyone.
Bye. I don't know if that-
Bye, guys.